In this encounter of the AI stress test, I want to show you guys something that would make every oncologist pause. We presented a case to the AI that has the typical complexity and nuances of the office case. There is molecular profile interpretation, staging, treatment selection, and treatment sequencing. Now, the AI gave a fairly reasonable sounding answer. However, buried in it are errors that, if followed, could have led to the wrong first-line treatment by today's standard. The error itself is subtle. It did not make up any trial name or make up any drug regimen. What it did was a little bit more insidious. It extrapolated data from an entire different tumor type and presented that as evidence. And that's what I want to show you today. Alright, so here is the case that we submitted to the AI. We presented in such a way that we would typically present on the tumor board with the basic information outlined here in the prompt. Essentially, this is de novo stage 4 colon cancer rising from the sigmoid. And what makes this case interesting is that the disease is HER2 positive, which we know is encompassing about 3 to 5% of all the colon cancer cases. HER2 is emerging in colon cancer as predictive tumor marker. So I want to see how the AI would handle the treatment and its interpretation. It was in the prompt, we also mentioned I want the AI to act as an oncologist, asking how it will manage the case. Be evidence-based, list the key decision nodes, and also the confidence level in its recommendations. Now that is a good problem strategy to have. It'll kind of let you know confidence level that the AI has. Of course, high confidence doesn't always mean correct. Now the answer is being generated here. The AI correctly stated that this is a stage 4 disease, and the HER2 status did get its attention, and that's the first decision node. And it also correctly mentioned here that we mentioned 3 to 5% of the cases. The second decision node regarding the first-line treatment, and this is what I want to draw your attention to. This is the first mistake that I see here. Now, as you guys are familiar with the current treatment landscape, at least by today's standard, the HER2-directed therapy has not quite yet made it into the first-line treatment. So this here would be incorrect by today's standard. FOLFOX plus trastuzumab, pertuzumab, that would be the wrong answer. And AI is actually recommending it as the first-line therapy. And let's see here, with moderate to high confidence interval. So besides this wrong recommendation, it mentioned consideration for enrollment in clinical trial, which certainly makes sense and is quite reasonable. Now, it highlighted the trastuzumab, pertuzumab plus FOLFOX and is actually citing the Mountaineer trial, which, as you know, it's an ongoing trial, at least at this time of filming. And it's actually studying a different set of medication than the ones that's recommending. So this is the first inconsistency that we're seeing. AI is recommending regimen with real medicines and citing a real trial, but the mismatch here is quite evident. And it lists the other appropriate regimen here, FOLFOX plus Bev. The other thing that I picked up that I was hoping that it would is that we know HER2 amplification is a potential resistance mechanism for anti-EGFR therapy. So it correctly pointed out that the anti-EGFR therapy ideally would be avoided, and with high confidence here. Now, in the summary of the recommendation, it actually highlighted that the consider for clinical trial enrollment, and if no trial, consider FOLFOX plus Bev as a standard treatment. So the recommendation up top, the trastuzumab pertuzumab regimen, has actually not made it to the summary recommendation. So another inconsistency within the answer that I generated. And the cited the evidence down here. So given its answer, which we know is incorrect at this time, I'm going to give it a pushback and to see if it would reverse course. So we mentioned I wanted to cross-reference to the most recent guideline and also to check this particular regimen at today's date and see if that would change his recommendation. And it actually tells us that it's a good catch. It actually thanked us for pushing back and that we're correct here and that was the wrong recommendation. And now it was able to reach the guidelines and know that it's not listed as the first-line therapy. So it was able to reverse course here. Let's see why it had listed the trastuzumab pertuzumab initially. This is quite telling from the AI. I'm glad that it's being able to be quite transparent regarding its mistake. It outright here said that it was a confabulation from the breast cancer guidelines. So the trastuzumab, pertuzumab, as you guys are familiar, this is from the Cleopatra data, was the dual HER2 antibody with chemo. And what had happened here is that AI saw the HER2 marker within the prompt, and it automatically pattern matched to where the most data is located, in this case within the breast cancer. And it incorrectly recommended the dual HER2 as a first-line treatment. Another thing that I had also mentioned here, the premature extrapolation from the ongoing trial. Certainly, Mountaineer 3 is an important trial that encourages enrollment, and it has the potential to be practice-changing. However, within the nature of the ongoing trial, the extrapolation, as the AI says, will be premature. So within the correct pushback, the AI was actually able to reverse course here. And also mentioned the treatment sequencing options. Again, the tucatinib plus trastuzumab or the HER2 regimen. So what we saw here is two different AI failure modes by today's models. One is that it's strong at pattern matching. However, the pattern matching is not always precise when it comes to molecular profiling, disease subtype, and even if it's following the guidelines itself may not be the correct one that it's looking at. So that's one thing to be aware of. The other is that the over-extrapolation of emerging data. Certainly, the guidelines will always lag behind some of the publication. But what the AI did here is it took ongoing trials and extrapolated that to current practice, which is not yet standard. And that shouldn't be the automatic approach with the initial prompt. So next, let's ask for AI's feedback. How can we prompt better so we can avoid those potential errors? So the first thing that I have recommended is that how will you manage this patient? This particular phrase appears to be too vague. Of course, this is kind of how we would discuss at tumor board between clinicians, hey, what would your management be, etc. However, the AI's feedback here is actually that's too broad. They want us to mention, according to the guidelines, what would be the first-line recommendation, or those more precise or narrow questions. Another thing here that it had recommended that I think would be worth trying is to separate into evidence tiers based on FDA approvals, completed trial data. So what this is teaching us now is that in prompting the AI, it's not just looking for its answer, it's also in telling it what not to do, not to recommend treatments that's not currently approved, not to extrapolate data from different disease type. And the other thing that I mentioned here that I think would be worth a try also is the two-step verification approach. Generate the initial recommendation, and then with the second prompt, have the AI audit its own answer following specific guidelines and avoid extrapolation. So those are things that I think will be worth a try in future prompting. Now, those are certainly not complicated prompts, but they have the potential to change the output dramatically. And at the end here, it actually gave a really honest answer. It mentioned that the AI is good at pattern completion, which why is matched to the breast cancer paradigm. It also boldly said here that these are some of the same cognitive errors that humans can make, which is certainly true. But the issue here it also raised is that it does so quite confidently. And given the large language model nature of the AI, all its answers are going to sound quite confident, regardless how confident it is. Of course, quote unquote confidence, those are what users assign to how user or the reader interpret its answer. So certainly we need quite a bit of caution here. The lesson from this AI stress test is not that the AI is unreliable. The AI is actually quite fluent. However, fluency without accuracy is a real risk here. It gave a fairly reasonable sounding answer that would have passed by a glance. However, it's only requiring the clinician really knowing the treatment and the data behind it be able to catch those errors. And in today's AI world, your clinical knowledge and your familiarity with the data behind each of the treatment become more important than ever. It's only with those knowledge that we're able to catch those errors. So your job here is not to accept the output blindly, but to interrogate it. And the framework here that we give will give us some structure to do so. And this is what the Oncology AI Lab is about. Not whether AI is good or whether AI is bad, but whether us as clinicians are equipped to use those tools rigorously. I'll see you on the next one.